Hi everyone, this is Abby, and for my clinical pearl today, I'm going to be talking about some new recommendations for hepatitis B virus screening in the oncology patient population. So I think we are all familiar with some of the recommendations for hepatitis B virus screening for some of our immunotherapies, such as rituximab, for example. This clinical pearl was really prompted by different conversations that I was having with various people throughout the past couple of weeks, saying that they had noticed within Lexicomp for some of the traditional chemotherapies such as paclitaxel and cyclophosphamide, that there was a new recommendation by the American Society of Clinical Oncology to test patients prior to chemotherapy for hepatitis B virus infection and do the recommended screening. This was something that was really unfamiliar to myself and really prompted further investigation to see where this recommendation was coming from. Looking at the American Society of Clinical Oncology, or ASCO, they publish provisional clinical opinions, and these come infrequently. However, they do come when there is new evidence or there is something that really prompts a new PCO. So looking at 2010, a PCO was updated for the hepatitis B virus, and the ASCO at that time recommended that hepatitis B virus infection screening was recommended in patients receiving anti-cancer therapy for the treatment of malignant diseases. In 2015, they also had an updated PCO that introduced a risk adaptive clinical algorithm to help clinicians identify and treat patients with HBV infection to reduce their risk of HBV reactivation from anti-cancer therapy. And finally, in 2020, ASCO released the newest PCO that states HBV screening and management should be universal. And so HBV serologic testing should be done for all patients at the onset of anti-cancer therapy. And so this is what is really prompting those recommendations to now be a part of those traditional chemotherapy monographs within Lexicomp for the recommended monitoring. Just to expand a bit more on the history of these PCOs, the recommendation in 2010 stated to consider screening patients belonging to groups that ASCO considered to be at a heightened risk for chronic HBV infection, or if they were receiving highly immunosuppressive therapies such as rituximab or a stem cell transplant. In 2015, these recommendations were further expanded upon, stating that clinicians test patients for HBV infection before starting anti-CD20 therapy or stem cell transplantation, and that providers also test patients who have risk factors for HBV. And now to expand on the current recommendations from 2020. ASCO is recommending that all patients with cancer who are anticipating to receive systemic anti-cancer therapy, they should be tested for HBV by 3 different tests. So utilizing the hepatitis B surface antigen, the core antibody total immunoglobulin, so the IG or the IgG, and then the antibody to hepatitis B surface antigen. And this should be done prior to or at the beginning of systemic anti-cancer therapy. They also state that the anti-cancer therapy should not be delayed for the results of these screening tests. However, if findings of chronic HBV are found, this would require further action. And this recommendation is evidence-based with benefits outweighing harms, and the strength of the recommendation is strong. Also, to further expand on the new recommendations, patients with chronic HBV that are receiving any systemic anti-cancer therapy, they should receive antiviral prophylactic therapy for the duration of their anti-cancer treatment, as well as for at least 12 months after completing chemotherapy. If they have past HBV and they're receiving anti-cancer therapies associated with an established high risk of HBV reactivation, such as the anti-CD20 monoclonal antibodies, or if they are going to receive a stem cell transplant, they should be started on antiviral prophylaxis at the beginning of anti-cancer therapy and continue that for at least 12 months as well. This type of recommendation is informal consensus with benefits outweighing harms, and the strength of the recommendation is strong. This chart dictates a summary of the recommendations in a flowchart format. So up at the top, again, ASCO is recommending to test all patients for HBV using the 3 tests before anti-cancer therapy. Then looking at the evidence of HBV infection. This will either be evidence or no evidence. If patients are displaying evidence of having HBV infection, this is further broken down to if it is chronic HBV or past HBV. If it is deemed to be chronic HBV, looking at the left side of the flowchart here, it's further broken down into if patients are going to be receiving systemic anti-cancer therapy, either it being a cytotoxic agent, immunotherapy, or targeted therapy, or if they're just going to receive hormonal anti-cancer therapy alone. If they do receive systemic anti-cancer therapy that is the cytotoxic, immunotherapy, or targeted, again, the recommendation would be to start antiviral prophylaxis and continue that for at least 12 months after the last dose. It's also recommended to check HBV DNA and also ALT at baseline and every 6 months during antiviral therapy. After the anti-cancer therapy, it's recommended to monitor ALT levels for hepatitis flares after stopping the antiviral therapy. And then it's also important to note that patients may need long-term antiviral therapy. And then finally, consult an HBV specialist for co-management if they are available. If patients are just receiving the hormonal anti-cancer therapy and they do have chronic HBV, there is currently no recommendation for antiviral prophylaxis. So they shouldn't need that unless antiviral treatment is needed independent of the anti-cancer therapy. For chronic HBV, consult an HBV specialist if they're available, and then consider the long-term antiviral therapy if that's appropriate. And then for past HBV, no further monitoring is necessary. For patients deemed to have past HBV, again, it will be important to determine what type of therapy they will be on, so either hormonal anti-cancer therapy alone, anti-CD20 therapy, or all other systemic anti-cancer therapy. If they are on the hormonal anti-cancer therapy, this recommendation is going to be the same as I previously read. With the past HBV, no further monitoring is going to be necessary. For the anti-CD20 therapy or stem cell transplant, it's recommended to start the antiviral prophylaxis, and again, making sure that we're continuing that appropriately, and then checking levels and making sure we're monitoring for any flares, hepatitis flares, after we do stop the antiviral therapy. If patients are going to be receiving anti-cancer therapy, cytotoxic, immunotherapy, or another targeted agent, it's recommended just to monitor and then to check labs and make sure that patients are not having any reactivation that's occurring. And this is recommended to do every 3 months during that therapy. Again, if there is a hepatitis flare, it's recommended to check important labs such as the HBV DNA. And then if that DNA is greater than 1,000 international units per mil, recommended to start antiviral therapy immediately. I also wanted to evaluate some of the data that is surrounding this topic. In 2015, Brazier et al. Published a study of 388 patients with a solid tumor who completed a brief survey about potential risks for HBV infection. The investigators found that the sensitivity and specificity of the HBV risk factor questions were 46% and 56% respectively. Therefore, they concluded that this had a poor positive predictive value of 9%. Therefore, using this selection tool is discouraged as an HBV risk factor approach. In 2019, Ramsey et al. Published a study of HBV, HCV, and HIV screening in 3,051 patients with a hematologic malignancy or a solid tumor awaiting any anti-cancer therapy over a 42-month period. When looking at the prevalence for patients who had chronic HBV, this was 0.6%, or 19 of 3,050 patients. 21% had no known risk factors for HBV, and this was equal to an N of 4. When looking at past HBV, the prevalence was 6.5%, or 197 of 3,050 patients. 27% had no known risk factors. This equaled an N of 54. Therefore, authors concluded that given a large portion of patients with chronic or past HBV had no known risk factors, they concluded that evidence indirectly supports universal HBV testing. I also wanted to investigate to see how prevalent HBV is. And so when looking at the incidence of HBV reactivation within the cancer patients, looking at the reactivation in patients who do have the hepatitis B surface antigen positive, if they are receiving cancer chemotherapy, this has been reported to range from anywhere from 20% all the way up to 57%. HBV reactivation was also observed in 50% of patients who were positive receiving rituximab-based therapy. And then finally, HBV reactivation rate in subjects with negative antigen and positive anti-HBC was 3%, with ranges from 2 to 25% in those receiving rituximab-based therapy. And finally, what are the consequences of a patient who does have HBV reactivation? This has been associated with jaundice in 10% of patients, fulminant hepatic failure in 6% of patients, and also cases of death have been reported. The overall liver-related mortality associated with reactivation has been estimated to be 5%, and then in patients with de novo HBV-related hepatitis, fulminant hepatic failure developed in up to 38% of patients, which is a rather large number when we're thinking about all the patients who we do treat down in the Cancer Care Institute. Patients with HBV reactivation also had delays or interruption of chemotherapy schedules or premature termination in 68 to 71% versus 19 to 31% of patients who did not have this disease. This may itself actually be associated with decreased cancer survival, as patients who are not able to stay on track with their chemotherapy or their treatments. Obviously, having delays is not ideal. As we can see here, the consequences if patients do have the HBV reactivation can be rather detrimental and something that we do need to have on our forefront when we're treating these patients. So finally, I wanted to leave you all with just thoughts of what we have discussed and prompt some discussion for if we feel like we need to add HBV testing into all of our treatment plans for patients who are going to be considered for receiving any type of therapy, whether that be our traditional chemotherapies or the immunotherapies. Again, this is something that ASCO is recommending. However, I think we do need to have a discussion and really see if this is felt to be important, specifically within our patient population that we see at Monument Health. Here are a list of references that I utilized for preparing this clinical pearl. If you guys have any questions or wish to discuss further, please do not hesitate to reach out to me, either in person or email. My email is aferdinand@monument.health. Thank you.